and your name. So as always, we'll ask if anybody has a cool case they'd like to share, or a not cool case. I think we can make anything fun and educational.
You're saying all cases are cool.
Yeah,
pretty much.
Not on the surface cool case, I guess. And then we'd love to have some new voices join us in discussing the case. So please share if you'd like to participate most actively in that way. And in the meantime, we'd love to just hear what people are up to and what's new in y'all's lives and what's new in medicine. Don't be shy. We're such a small group. We should become best buds by the end of this.
World Cup, yes. Laura. It's getting exciting. Down to the few.
I could guess based on the name, but what's your team?
Brazil.
Okay. I was gonna say.
Now the US is not in the World Cup, you guys had choose a team. Brazil? Maybe?
I'll put in a vote for Croatia. That's actually always one of my favorites to cheer for too. And they squeaked through to the next round. So
Steph's family is half Croatian, and we've actually visited some distant relatives there. So I gotta go Croatia too. It doesn't hurt that they're an underdog too, so that's always fun.
I gotta say, I probably told you I wouldn't be distracted when I'm driving, but here I am. I have to say, go Brazil. Been a lifelong Brazil fan. In Lebanon, where I grew up, you have two choices. Either you support, because Lebanon's never in the World Cup, you either support Brazil or you support Germany. And I just grew up loving Brazil. I had like a mohawk with the Brazilian flag as a 7-year-old, which is the most out there I've ever been, probably. But I'm right there with you, Deborah, and excited to see how things go.
The first World Cup I ever watched was 1994, and the final was Italy-Brazil. And for whatever reason, I randomly chose to root for Italy. And Roberto Baggio famously missed that penalty kick, and Italy lost. Since then, for some reason, that 8-year-old me always had a beef with Brazil, but it's slowly softening up.
Oh, Anne-Marie said she's got a case on the fly that she could do. Awesome. And Madalena's gonna, multitask. I was impressed before that you said, oh, I can scribe and do teaching points at the same time. That's a commendable.
I actually think Deborah's gonna jump in too. So I think she'll be able to help out.
And
but
Deborah,
I'll share my screen so that you can see the whiteboard.
Deborah, you're going to help out with the writing, or are you going to discuss?
I will help with the scribing.
Okay, cool. Would anyone like to think through Anne-Marie's case with us? Hi, Joy. Was that a yes? Thank you so much. Joy, I don't think we've met. Do you mind saying hi to everybody and sharing where you are and what you do?
There you go.
So yeah, I'm actually applying for neurology for this month. Yeah, this month season, and it's a little bit hard because no interviews yet. So yeah, also I want to obviously think about other parts of the body. Then I'm just been more concentrated on the brain, the rest of the, of it. So, and plus you have to be a really good, I heard like one neurologist said, to be a good neurologist, you have to be a good intensivist, or I mean, internal medicine. Like it's neurology is basically internal medicine for the brain, something like that. So
It's
yeah.
very well put. It's nice to meet you, and thanks for joining us.
Here, I've been a fan of you guys. I've been like watching, some of the videos and learning so much from you. The how you guide learners like me, it's amazing to me. So obviously I did all my education abroad, and a little bit of training. It's totally like night and day difference. So yeah.
Well, thank you so much for engaging with us. Well, I'm pretty excited to hear what Anna Marie has in store for us, and we'll have a fun journey.
And Yasmin, we'll take you up on your offer to chat through things with us also. I don't know if you want to say a quick hi to the group too before we get started.
Oh, of course. I can definitely give some of my input. Thank you so much. I don't really connect with VMRs, and I'm really part of the team. And yes, like I really like talking to everyone, and I've seen Joy already like discuss like with Dr. Aaron, so I know that she will do great.
Awesome. Thanks, Yasmin. We're excited. All right, Anne Marie, we'll let you kick it off.
Okay, so this is a case of a 36-year-old male, and the chief complaint is lower back pain. Past medical history includes diabetes. It's unclear if it's type 1 versus type 2, diagnosed in high school, had been on and then had tried oral hypoglycemic agents, and then
Anne Marie, sorry to interrupt, but I don't know if it's the speaker again, but your voice suddenly got very muffled out of blue.
Okay, is this better?
A little bit. It suddenly got still a bit softer.
I am not sure why.
Oh, it fixed for 1 second. I don't know if it's connecting to Bluetooth speakers on and off or something.
Let me check. Can you hear me? Can you hear me now?
Still soft, but we can hear you.
Okay, I can, maybe I'll go in the discussion and grab a mic that I can plug in to make it easier after this, but I'll just try to talk loudly. So on and off insulin versus oral agents ultimately had been off for several years due to just kind of not following closely with a primary care doctor. And so noted onto the HPI, noted 6 weeks of lower back pain. It first started at work when he was lifting something, would often have to lift packages for the work, had been taking ibuprofen, and then had gone to urgent care and been prescribed prednisone at some point. But kind of the details of this aren't clear, wasn't able to tell, and then couldn't find records. There's no radiation of the pain, kind of feels weak all over, but no localized place, no loss of sensation, numbness, or tingling. Does have constipation, but no bowel or bladder incontinence or saddle anesthesia. He's recently had persistent vomiting and decreased appetite, as well as a 20-pound weight loss over the past several weeks. No cough, shortness of breath, didn't notice any fevers at home, but maybe some night sweats, no dysuria or sick contacts. And I think I will leave it here. Did my voice ever get better, or was it still quiet?
It's better overall. Thanks, Anne-Marie. Joy, maybe you and I can sort of share our thoughts on this first section of the case together, if you want to make any comments that come to your mind.
So I'm immediately thinking of neuromuscular here, the lower back pain. Obviously, it's sounding to me like
Yes.
I think Joy briefly got frozen.
like some sort of going on for a while.
Joy, I think we're losing your connection on and off, just so you know. Getting frozen intermittently. But I think, you know, you made a great point about really worrying about the chronicity in this case in the context of what sounds like poorly controlled diabetes. Already is raising some red flags about what it could be. Yasmin, I don't know, Joy may get unfrozen in a second. I don't know if you want to give any other initial thoughts here before I jump in.
Of course, I hope Joy can defroze soon. But as she was saying, yeah, in this patient with lower back pain, I will first go to the red flags. He has 6 weeks of back pain. I would definitely ask if this pain improves with rest or worsens at night. That would be my first question, because he's having these symptoms of weight loss, of decreased appetite, of some night sweats, which for me would be I will look for malignancy, because it's a very broad topic, back pain. It could be mechanical, degenerative, it could be inflammatory, oncologic malignancy can be one of the reasons for back pain, and infectious. So having B symptoms can make me think about I have to discard malignancy. So I will ask for red flags symptoms in this patient. Also, diabetes mellitus, a patient with immunosuppression, with issues, I would like to dig a little bit more into this. If he has been using insulin, if he is diabetic or not, like I would like to really dig into this, because it can be one of our predisposing factors.
Beautifully said, Yasmin. And I totally agree with you, where there's a lot of factors that make us worry about this gentleman. I want to say, I mean, Anne-Marie did just something that was incredibly helpful and expert in the storytelling, which is actually giving this background first of a longstanding history of diabetes, probably without good control, since this person has been off medications, which completely reframes how worried we are about this 36-year-old man. Back pain, as we've seen in clinics, it's one of the most common chief concerns that people come in for care with. And most of the time isn't something scary, right? Most of the time it is a more benign musculoskeletal injury, particularly in a young person like this. So I think we're obviously going to kind of get into a case where something concerning is going on. But we talk about the theme of base rates of disease a lot of the time, and a musculoskeletal strain, particularly related to his work or just daily activities, is really the most common thing that could happen in a 36-year-old gentleman. And these guidelines would say you don't do any imaging, right? You provide some supportive care and reassess whether it gets better, even up to a period of several weeks. But Yasmin, you're totally spot on. We have a lot of concerning factors here that I'm wondering right now whether they are because of whatever is causing the back pain, or are they actually manifestations of his uncontrolled diabetes and not directly related to the back pain itself? But for example, is he really been in a catabolic state because his A1C is incredibly high? Has he even been in DKA more recently to explain some of the nausea, vomiting, pain that he's having? So I think at this point, whether those symptoms are from the cause of the back pain itself versus a marker of how advanced his diabetes is, which of course puts him at risk for many of those concerning symptoms of back pain that you mentioned, Yasmin. Either way, we're very worried about this guy, even though he's 36, coming with the back pain, whether it's the back pain or these concerning symptoms that could speak to just systemic illness in the setting of diabetes that isn't controlled. Let's maybe get a little more from Anne-Marie.
Okay, can you hear me now?
Great.
Okay, perfect. So as far as meds, he, other than the ones I mentioned, hadn't been on any before he came. As far as family history, Dad had some high blood pressure, some like family history of diabetes, no known family history of malignancy or autoimmune disease. And as far as social history, he denied any travel ever outside of the country, no history of incarceration, no known exposures to a person like with TB, no kind of like weirder abnormal activities, lived and worked in the area, no tobacco, alcohol, or other drug use, lived with friends, and then no significant allergies. As far as his vital signs, he was originally a febrile, but then had intermittent like temperatures up to 39 degrees throughout his hospitalization. He was tachycardic in the 120s to 130s that did not improve after fluid resuscitation. His blood pressure was systolics in the 110s, diastolics in the 70s to 80s. And respiratory rate was between, let's see, sorry. It was between originally in the higher 20s, and then went down. On exam, he just appeared cachectic. And this is not an exam I did, so I'm just looking at it. And like very uncomfortable, like in his back. He was like rolling around at the time due to pain, was tachycardic, but a regular rhythm without murmurs. His lungs were clear, although he had slightly diminished air movements in the lower lung fields bilaterally. His GI was normal, soft, non-tender, non-distended. On MSK exam, the extremities were just a little bit cool, but he still had strong peripheral pulses. No edema was seen. He had lumbar back pain, worse around L4 and L5. Was noted to have very slow responses to questions, but otherwise was alert and oriented and able to answer simple questions. Preserved sensation, diminished deep tendon reflexes bilaterally, no increased tone, no myoclonus. And then it looks like maybe just about like 4 to 5 muscle strength, but it was equal bilaterally and non-focal. And then he had just a little bit of dark thickened skin on the right medial aspect of the lower leg. And I will stop it there.
Wow, that was so much great information, Anne-Marie. Can you, I missed some of it though, the abdomen, you said it was there something abnormal in the abdomen?
The normal.
Wow, fascinating. Is Joy back by chance?
I don't think she made it back, unfortunately.
Oh, bummer. Okay, Yasmin, do you want to comment on any of this aliquot?
Yeah, like did he had any subtle anesthesia or any incontinence? He didn't. He only had issues Okay, so he only had lower back pain. His reflexes were, oh, no, his tone was diminished. So he didn't have, maybe he could have a spinal cord compression. I don't think he had a spinal cord compression because his bladder and bowel function is not, he doesn't have any issues. So I wouldn't really think he has a tumor going on in the spine. His dark skin is something that is like his hyperpigmentation is making me think about maybe is he having a hemosiderin deposition? He is diabetic, so what if he had a, I don't know, like maybe think about hemochromatosis, or maybe he has I will also think about Addison disease or any other malignant process as I don't know. I think we should. I would think more about this hyperpigmentation. Why is this person having issues with hyperpigmentation? I will look at his ferritin. I will look about his iron levels, because he's having diabetes and he's having hyperpigmentation. So for me, it could be hemochromatosis or something like this. He's having lower back pain. So maybe it's that's the first thing that comes to mind, but I don't know what you may think.
Those are great thoughts. And I love how when we hear this unusual finding that you don't see every day, it's really important not to dismiss it, right? And to really think about how it may overlay or interact with, with everything else we're dealing with, and some of the causes you mentioned of abnormal kind of skin tone or pigmentation relative to once prior, even though we think of those things as systemic, right, kind of diffuse processes, whether that's the adrenal insufficiency and the increased melanin there, or iron deposition, whatever. A lot of times it, in the skin, it can manifest asymmetrically or kind of patchily, and especially in areas of old injury, trauma, scars. So you don't have to have a completely diffuse kind of presentation to be dealing with a diffuse process. And that really goes for a lot of things. That being said, taking a step back to like the first thing we just got, which was the vitals, he's clearly, febrile, very systemically inflamed. And in the categories of infection, sterile inflammatory disease, or cancer or endocrine disorders, I worry most about infection in this patient, just because of base rate, the time course to some extent, and the but malignancy can't be excluded either in this case. So what did anybody else kind of think it was funny that the patient's kind of rolling around, unable to get comfortable? Or was it just me? You too, Steph?
Mm-hmm.
How come?
I've associated that sort of like squirminess with kind of colicky kind of pains. The pain that can come with kind of nephrolithiasis, it can come from, can come from GI etiologies, other GO etiologies also. But if this is a musculoskeletal issue, which was one of the first things that Joy kind of shared with us, I would expect movement to make it worse. And so it just strikes me as a little unusual, and makes me want to just think broadly about kind of what could be causing the back pain, including referred pain there in someone who's so sick.
I think I got the same sort of eyebrow raise for a second. But I think this you know, this is probably still a skeletal kind of spine problem, right? It is musculoskeletal, the pathology. That's my best guess. And, you know, I actually wanted to share from the beginning, just like the counter example to this case, which is I am also a 36-year-old man. And I also currently have low back pain. I'm not kidding.
His temperature is not 39 degrees.
Yeah,
though.
but these are the differences. I've had it for about 3 days. Okay. Since playing tennis a little too hard, I've had it a million times before from things like playing basketball or tennis, or, you know, not, I guess, exercising my core enough or something. I've only had it for 3 days, right? And I have a normal temperature, but no, just from that experience, actually personal experience, there are times when it is, you know, a lumbar radiculopathy, and it actually is really hard to find any comfortable position. But after staying in any one position for more than a couple of minutes, you feel like you need to sort of like shift and maybe try to find a different, less uncomfortable position. Yeah, so I think this, I think it's good to notice that sort of the different types of pain and patterns of pain and alleviating factors that are positional, but it's not a perfect differentiator, of course.
Brendan, you make a fantastic point about ED stretchers not being, I've never met anyone who says, oh yes, this emergency department bed is comfortable. So I think we, don't need to overinterpret that squirminess in an uncomfortable bed in an uncomfortable situation. Yeah.
I also want to comment. Okay, so I think everybody, you know, by the way, like the chat has just been absolutely amazing, and I hadn't heard of that mnemonic for the red flags, and I love tuna fish too now. But no, I think everybody's really seems to be sort of worried about potential, you know, inflammation, back pain. It's severe. There could be sort of a focus there, and I suspect everybody here really wants to see some pictures of the spine and of the kind of lumbar muscle and bony and fatty soft tissue, everything, right? But the description of the patient's conversation of their mental status stands out to me a lot, because 36-year-old people who are in the emergency department with acute symptoms, they should be on, right? They should be, you know, worried, anxious, engaged. That like sympathetic tone should make them quicker to respond, right? Like more engaged. And the fact that there's some kind of cognitive slowing or drowsiness, that to me means a lot too. And it could be just part of a systemic illness. But the younger and healthier your brain, the worse of a systemic illness it should take for you to have any kind of brain dysfunction. So for a patient like this, I actually worry about something neurologic, not just in the peripheral nervous system, but potentially in the central nervous system too. Or maybe there is something metabolic that we just haven't seen yet, you know, his sodium's 118 or whatever, that would explain, you know, cognitive slowing or dysfunction in a young, otherwise healthy person. Anybody, was there something that we should have commented on but didn't? Just
just appropriately comments about imaging this guy.
Yeah.
Which makes complete sense. And Joy's back. Welcome back, Joy. Should we get some more,
Yeah.
Anne-Marie? And then Joy will tag you back in for next Alquat.
And the BMI was around 24, by the way. I forgot to include that earlier. As far as the labs, the WBC was 7.5 and notable for mild lymphopenia, otherwise normal. The hemoglobin was 12.6. The platelets were 283. And then as far as the comprehensive metabolic panel, the sodium was 134, the potassium was 6.9, the chloride was 94, the bicarbonate was 23, the anion gap was 17, the BUN was 36, and the creatinine was 1.58, previously unknown baseline creatinine. And then the glucose was 886. The calcium was 9.7. The albumin was 3. The total protein was 8.3. The AST was 28. The ALT was 22, and the alk phos was 1,027. The beta hydroxybutyrate was 3.79. Normal lipase, hemoglobin A1C greater than 14. And then the magnesium level was normal. Phosphorus level was high at 5.6. High sensitivity troponin was normal. Blood cultures were obtained. A VBG showed 7.32, a CO2 of 55. And then lactic acid was 2.9. And then HIV was negative. And then acute hepatitis panel was non-reactive. And I think, let me see. And then the initial chest x-ray had question of a left retrocardial opacity, atelectasis versus pneumonia versus mass, and dilated hyla concerning for possible nodes or pulmonary arteries. And then an ECG just showed sinus tachycardia, and TSH was within normal limit.
What was the last thing? Was
TSH.
TSH?
Yeah.
Oof, we've got a lot of information, Joy. Do you want to start by just tackling even the basic metabolic panel?
Yeah, sure. So the lymphopenia, that's there's that, and this could be going towards the looking more like an infectious process here, or something inflammatory. Like I'm also seeing there's some sort of gap between the total protein and I'm not sure, and the albumin. That could be some sort of paraproteinemia going on there. I'm not sure. And what's striking is the hyperglycemia. Obviously, I mean, you kind of expected this because they are diabetic, and not sure if it's type 1 or type 2. But I'm not sure if that's they are in ketoacidosis with that level of beta hydroxybutyrate. Not sure. And they are the lactate, though it's a little bit low, so they are in acidosis. Given that they are obviously they are in they are in a inflammatory state. I would say. Yeah, that's all I have. Sorry.
Yeah, fantastic. Fantastic just approach walking through those. A lot going on here. I think in regards to the lymphopenia, absolutely could go with kind of systemic infection, kind of relative glucocorticoid compared to kind of other hormones. And Adam made a great point about an HIV being an important test in this case, which we do have as negative. Just want to point out, he's got a normal white count though, right? His temperature's 39. He's really sick, doesn't have a leukocytosis. Just worth noting that that's not the only signal, of course, we have of systemic inflammation, which is normal in him. Joy, you're spot on that beta hydroxybutyrate it's a little bit elevated. So it does seem like we have a pattern here of an ana and GAP metabolic acidosis that's driven partly by the ketones as well as that very mild lactate elevation. Just as you said, we weren't surprised, right? We thought perhaps we were going to see a hyperglycemic crisis here. I will say the glucose of 800, it's really typically kind of out of the range often for standard DKA, but whether whether we kind of treat this as HHS versus DKA, really the foundations are going to come down to fluids, insulin, making sure his electrolytes are repleted. I think the big thing this case has illustrated to us is the hyperglycemic crisis is probably a symptom of something else going on. And I remember once learning the mnemonic for hyperglycemic crises of the instructor saying, I want you to remember the triggers, with the letter I being the mnemonic, where someone with type 1 diabetes simply being off insulin is enough to cause DKA. But there's many other I's that can tip someone over into this metabolic disarray and state, which include infection, as we've alluded to, iatrogenesis. So he did get a course of glucocorticoids and prednisone at some point in this illness. For some patients, that iatrogenic medication can do it. Intoxication with substances can cause hyperglycemic crises. Inflammation, meaning sterile inflammation, can do it, like cholecystitis or pancreatitis. Ischemia, infant, if you're a woman and you're pregnant. So this is just a really demonstrative case that seeing a hyperglycemic crisis is often an indication that there's a major underlying issue going on. Now, this person has been on off insulin and we're not sure they might have type 1 diabetes. But either way, we know there's a major systemic illness happening. I think the elevated ALK phos is a really important signal to tackle also. I believe the AST was normal also. And so really we're seeing an isolated ALK phos elevation. Mm-hmm. Our approach here is really to figure out, is this of a hepatobiliary source or not? Which, depending on your hospital's lab capabilities, you can actually fractionate the isotype of ALK phos, or even just checking a GGT also, if that's elevated, will tend to signal hepatobiliary source. If this is hepatobiliary, this liver injury pattern is called an infiltrative pattern, and really speaks to something in the liver that is infiltrative. And really it boils down to a few things that include granulomatous processes like tuberculosis, sarcoid, syphilitic hepatitis presents with an infiltrative pattern, and then malignancies, whether primary tumor versus metastases in the liver. And then interesting, hepatic abscess also often presents with an infiltrative pattern. Big thing, though, is if we find, in fact, that this isn't from hepatobiliary source, bone is, of course, is
GGT is 90.
Oh, GGT is 90. That really, so it really makes us look for non-hepatic sources. Bone is going to be a big concern in this gentleman, right, given the predominant symptom of back pain. By the way, Joy, great pickup on the globulin gap that we haven't explained yet. He is hypercalcemic, right? And so I think, is he not?
9.7.
Okay, he's not hypercalcemic, but I think given the syndrome we've gotten, bone is one of the big concerns. ALK phos can come from small bowel. For example, in small bowel obstruction, it's normally produced in the placenta when someone's pregnant, but I think in this case, we're really worried about a bony source for the ALK phos at this point. I think only other comment on the labs, again, Joy, kudos on picking up that globulin gap. When we see that there's a gap between a high total protein but a low albumin, we need to think about whether there's a monoclonal excess of proteins versus polyclonal. Polyclonal happens in conditions like HIV, hepatitis C, autoimmune hepatitis, and then monoclonal, of course, helps with we've seen plasma cell disorders. So in this case, I think checking an SPEP and serum free light chains will be an important thing to figure out exactly where that excess protein is coming from. And then the abnormal chest x-ray. I think given how sick this person is, we're really going to need more definitive cross-sectional imaging to know what's behind the heart, what's making the hyla look large. It does seem this person has multiple primary acid-base disorders going on. He's acidemic with both an anion gap, metabolic acidosis, but his CO2 is way too high to just be compensating for a primary metabolic process. So seems like he probably has a respiratory acidosis going on as well. So just multiple reasons for us to look a bit closer in the lungs in this person who's so sick.
I have a question. So if you were like at this point taking care of this patient at this point, would you consider like intubation for this patient, given the high CO2 and that you pointed out and the lactic acidosis?
I don't think so. It seems like he's, you know, his respiratory rate is fine. He's oxygenating well right now. I think at this point, reacting to the labs as opposed to just how he looks in front of us would probably take us down the wrong therapeutic course.
Agreed.
So he's originally admitted to the ICU for DKA HHS spectrum, treated with an insulin drip. His glucose and labs improve. He gets an MRI of the spine, and this is actually, he gets a like full cervical thoracic lumbar spine with contrast. That shows multifocal heterogeneous bone marrow signal and patchy enhancement throughout the spine. And then there was mild left hydronephrosis and a small left pleural effusion. And then additionally, there was a possible like left-sided renal mass as well. He does get some additional studies. He gets an SPEP with immunofixation, which does not show a monoclonal process. He gets a UPEP as well, that also is not significant. His blood cultures come back negative at 48 hours. He does develop an oxygen requirement of 2 liters, so is started on just community acquired pneumonia treatment with ceftriaxone, azithromycin, and then with a 2-view chest x-ray showing possible hilar lymphadenopathy. Let me see if there's and then an ACE level is also checked, which is 29, which is within the normal range. After he gets fluid resuscitation, his hemoglobin drops quite a bit to the 8s. His creatinine kind of settles in the 1.2 range. He does have some urinary retention and a Foley is placed. And I forgot to mention, but the urinalysis originally showed like ketones, but was otherwise fairly unremarkable without like pyuria or RBCs. Do you all want more information or just to talk about this now?
I personally am overwhelmed. Would love to just be able to digest a little bit. Yasmin, do you want to get us started?
Yes, I was thinking, honestly, well, maybe it's multiple myeloma, but then I see the SPEP is not monoclonal process. So it totally erases my diagnosis. The thing is, I was thinking also of an adrenal insufficiency because this patient had weight loss, anorexia, fatigue, the metabolic findings. And then I'm just thinking, he has a renal mass. Could it be the cause of his problems, like a urothelial tumor? The cause of these problems, but then again, I am not sure.
Yasmin, I will say a morning cortisol was checked and was 19.5.
Oh, cortisol was 19. Okay.
Oh, okay, no, then thank you. I didn't hear about the cortisol. So then for the renal mass, I was thinking that could be the cause, but I'm not really sure. What do you think?
This is so tough, right? Like we had a lot of initial theories. A lot of them are kind of coming up negative, which is, bad in that we don't have a diagnosis yet, but it actually does help us, potentially refine our problem representation a little bit, right? And I think for a case like this, where there's so much going on and we just like don't even know how to approach it, I think sort of making a problem representation, which is to say, sort of trying to pull out the most kind of salient features of the case that we, like, what are you going to type into Google, right, to like help figure this case out, or some differential diagnosis engine or whatever. What are the key features here? So let's do that. Everybody in the chat, if you don't mind, sort of practice writing a problem representation just individually, and everybody share. I think that will be a good exercise for all of us. And while y'all are kind of thinking and coming up with that, I'll just comment on, I'll sort of expand on what I mean by like some of the tests coming back negative are helping us out. So for example, like the hyperpigmentation and the potassium of 6.9, right? Like people were getting adrenal insufficiency vibes appropriately, but the hard part was that, the hyperpigmentation was this like very focal and unusual. And then the potassium, it's like, okay, this person's in sort of half DKA, right? And in renal failure, what if that's just sort of a metabolic consequence of that, and it doesn't necessarily have to be a signal for adrenal insufficiency. So, and along those lines, like, Anne-Marie, I don't know if you're able to quickly kind of help us out, but like, I would be really curious, like what this person's labs did, even just like 12 hours after resuscitation, right? Just some general, go ahead.
So, are you talking about just like as far as the potassium and the creatinine and the hemoglobin, or?
Yeah.
Essentially still had the gamma gap closed some, but still had like somewhat of a gamma gap. The potassium normalized in kind of the high normal range, and then the creatinine normalized around 1.2. The alk phos remained elevated. Later had some AST and ALT elevation in like the 90s, mild, and then the hemoglobin went down to about 8 to 9 after fluid resuscitation.
Right. And the globulin was still abnormally elevated. It was about
I think there was like a mild gamma gap, but less so, less than 5, I believe.
Okay, so let's see some problem representations. Madalena has one. Would love to see some others. 36-year-old with history of poorly controlled diabetes, comes in with low back pain, found to have signs of inflammation. Cool. Focal hyperpigmentation, and hyperglycemic crisis. Anne-Marie's reminding us of the MRI, and I think that's a key part of the syndrome in this case. And in fact, like we were chasing after the alk phos, right? Like now that we see the GGT's normal-ish, and there's this like diffuse bony lesions, right? That's, you could kind of fold alk phos into that, right? And just mention diffuse bony involvement as part of the syndrome. The kidney mass is interesting. I'd be really curious to kind of talk to the radiologist, think about the spine as well as the radiographic appearance. Renal masses are so commonly seen incidentally. Most of the time they're cystic, and the percentage probability that you have at least one renal cyst is your age, above age 40 or so. But this guy's a little young, and if this is a solid mass, I definitely would kind of keep that on the short list of problems. The pleural effusion and now the hypoxemia is kind of weird in the hypoventilation. And the other thing I would include in the problem representation is there does seem to be, I don't know, is there neuropathy with the urinary retention, with the decreased reflexes? I wonder if there's a neuropathic process. Just if there was no kind of focal, cauda equina or lumbar spinal cord compression appreciated on the MRI, but there's now retention and all these other things. That's another sort of problem I would have on the list.
Yeah, so no like frank neuropathy, like grossly intact sensation. I will say with some of the weight loss he had experienced, and concerned that he really wasn't eating much, he was treated with high dose IV thiamine as well. Some of his anemia labs, he had like a ferritin, I think of in the thousands, like maybe 7,000. His B12, unremarkable, started on kind of like a multivitamin as well. And the blood cultures were negative, as was the urine culture. So he's treated in the ICU, given really aggressive fluid resuscitation, just like still tachycardic, having these like intermittent fevers, but never hemodynamically unstable. With the fevers, the lactate normalizes with fluid resuscitation. Because there's some concern about this like weight loss and everything like that, a PET scan is obtained. And the PET scan shows extensive multifocal uptake throughout the axial and proximal appendicular skeleton, concerning for malignancy. There are soft tissue structures that are difficult to resolve, but extensive uptake in the soft tissue density in and around, possibly replacing the left kidney, as well as the left adrenal gland, pancreas, and numerous metabolically active lymph nodes in the retroperitoneal, mesenteric, mediastinal, bilateral hilar, and left supraclavicular regions. And then the areas of increased metabolic activity in the bone are less mineralized, and it wasn't really able to quite characterize where the area, like the lesion, was coming from. And then it looks like now there's bilateral pleural effusions left greater than right, but no signs of a pneumonia.
Thanks, Anne Marie. Joy, maybe we can get some kind of final thoughts in before we hear. And I'll just say off the bat, yeah, a lot of people in the chat commenting about a biopsy is going to be important here. But curious, Joy, sort of what's on your list of things that could be doing this, infiltrating the bone around the left kidney and adrenal, lymph node.
Oh, and I forgot to mention, there's also left pleural mass. And I think also just thinking about, if we're talking about biopsy, where we want to biopsy, because it depends on like who we're going to get involved as well.
Great point. Thanks, Anne Marie.
So with this PET scan information that we have, I thought it could be one of the blood malignancies, but then we have the solid tumor in the solid mass in the renal, so plus the lymphopenia. So I'm not quite sure now, but it's I'm thinking definitely could still be a blood malignancy going on, given the age, the you know, the profile of the patient, the what's this, like I'm blanking out. So but definitely a syndrome here, like one of the that goes with the like a multiple endocrine syndromes, like the one of those, like maybe men, that could also explain their hypercalcemia, and yeah, something systemic, and yeah, their diabetes, multiple endocrine problem we have here, obviously, and that is now affecting the bones, and it has yeah, it has spread through the bones and the lymph nodes. Those are my thoughts, sorry.
Yeah, no, great putting together the major findings, Joy. And I actually want to point out something you didn't say that I agree just doesn't fit now, but was at the top of our differential diagnosis several aliquots ago, which was an infection, right? What infection? It's really hard to figure out what infection would cause diffuse bone, lymph node, as well as masses. So I agree, Joy. I wonder if we're shifting our differential into malignant, and I do think lymphoma would be one of the more likely, or other inflammatory but not really malignant processes causing this. So in that category are things like IgG4 related disease is a systemic inflammatory fibrosing process, causes masses and obstructions in places like of the ureters. Now he's a little young for that. It's usually older and it is more seen in men. But it does make me wonder about the whole category of histiocytic diseases, diseases of infiltration of cells of histiocytes that can diffusely go in the bone. And again, also basically cause kind of fibrosis and masses in other parts of the body with associated complications. So I do wonder if that could be a good fit for this gentleman, including kind of subcategories of that include diseases like Erdheim-Chester disease, et cetera. But we need tissue. Everyone's been saying in the chat. The question is, what's the safest place? And when it comes to picking a biopsy, you're balancing what's going to be diagnostic, actually get us an answer, but not super high risk for the patient. And I'm curious what Yasmin and Zavan think also. I wonder if this pleural mass is easy to get at, if a CT guided biopsy of that might be the lowest risk versus if there's a peripheral lymph node, although I worry a little bit about getting just kind of a reactive lymph node as opposed to the primary process. So my thought would be IR for pleural, maybe the retroperitoneal is just a little higher risk in the RP space.
I would probably just ask IR, right? They would know, and my guess would be that actually maybe the spine, the bony, somewhere, some superficial bony structure that is involved on the imaging, or a superficial lymph node.
Yeah. Anne-Marie, want to take us home and tell us how the case evolved?
Yeah, so did ultimately get a CTA as well, just with the oxygen requirement, persistent tachycardia that did not show a pulmonary embolism. He did develop a CT of the abdomen and pelvis was also obtained at one point, which did show like an incidental left gonadal vein clot as well as some gastric varices, possibly due to some compression on the splenic vein. And then had talked to Surgeonc about possibly going for the supraclavicular one, but because there was some concern about like renal cell carcinoma, decided to do an IR-based biopsy. And after they looked, decided to go for the pleural mass. Unfortunately, this is delayed several days. In the meantime, the pleural effusion is getting larger. And so you go ahead and do a thoracentesis that shows an exudative effusion, but normal glucose, normal pH, no signs of empyema in the pleural. Cultures are negative. Ultimately, cytology comes back negative of that as well. You kind of have this diagnostic dilemma because you found this like clot, but you're also trying to decide if there are gastric varices, it's higher risk to anticoagulate. So go between hematology and GI. At first, hematology did not favor anticoagulation, but later decides to do it. However, because there's concern for renal cell carcinoma, you need to MRI the brain, especially with some of which had been like ordered, but of course, like takes a couple of days to make sure that there's not metastasis, since those are so prone to bleeding. Thankfully, the MRI of the head comes back without any metastasis. Then you talk to GI and they do an upper endoscopy showing grade 1 varices, gastric varices. And there's kind of this question about whether or not you need to do a splenic artery embolization. And there's kind of some back and forth with that. MVIR ultimately gets a biopsy does develop some like kind of low-grade hematuria during the hospitalization. And I'll let you maybe, do you want me to give the biopsy results now?
I think so.
Yeah.
Okay, so the biopsy results actually, I need to pull them up to make sure because this came back after, but it's a little surprising. I think it showed adenocarcinoma with signet ring features, I believe, which again was a little bit surprising. Ultimately thought to be like a neuroendocrine GI tumor. Ultimately, kind of there's discussion about inpatient chemotherapy or not, but because of how aggressive it was, and then later developed worsening renal function and left-sided hydronephrosis, this is attempted, but unfortunately, it's so rapidly progressive that the patient later passes away while in the hospital. So that's that is the case.
Thank you for sharing that, Anne-Marie. What a complex case. Sad, right? Young guy for having such complex illness, very subacutely and then acutely. But just a lot of great learning points from hearing his journey through and all the therapeutic decisions that had to be made too about anticoagulating or not, what to biopsy, etc. Thank you again. And thank you, Joy and Yasmin, for sharing your thoughts and helping us think out loud on this. Madalena, we'll turn it over to you for some final teaching points.
Yeah, oh my gosh, Anne-Marie, just thank you so much for presenting this case. And you know, Steph, Zavin, and Yasmin, Joy, just really a fantastic discussion. So, you know, this journey started off with lower back pain, and we talked about how this is a very common chief concern, especially in the outpatient setting. And in the outpatient setting, it's almost always, you know, benign musculoskeletal strain. But we talked about how you really want to keep an eye out for some red flag symptoms to clue you in, you know, to see if there is a kind of concerning systemic process that you don't want to miss. So some of those red flag symptoms include, you know, trauma, weight loss, which was present in this case, some focal neurodeficits, an older age, fever, also present in this case, a history of IV drug use, steroid use, and a history of malignancy. In this case, when we got to the vitals, we saw that the patient was febrile and was systemically inflamed. So we immediately, you know, thought of some of the buckets of infection, endocrine, and malignancy. Initially, we were more concerned about infection just because of kind of the base rate and the time course in this case, but you know, that later kind of shifted as we got more information. So the labs gave us a lot of information. We first saw that there was some lymphopenia, which we thought was potentially related to the systemic inflammation. We also saw that the patient was acidemic with likely both an anion gap metabolic acidosis and a respiratory acidosis, really with kind of both ketones and lactate contributing to the metabolic acidosis. We also saw that this person who had had a history of poorly controlled diabetes was in a hyperglycemic crisis. And we thought of, you know, we learned that some of the causes for that is the self-limiting mnemonic is I want you to remember being all the words that start with I's. So that could be, you know, type 1 diabetes off insulin, infection, iatrogenesis, like glucocorticoid use, intoxication with substances, inflammation, and ischemia. We also saw interestingly an elevated alk phos, which was isolated. And we talked about how when you're thinking about an elevated alk phos, you want to think, is this hepatobiliary or not? You can check a GGP to clue you in that this is hepatobiliary. If it's not non-hepatic, you can think of bone and small bowel sources. We also saw a globulin gap in this patient, and we talked about that you want to think, is this a monoclonal or a polyclonal process? And just going back, a globulin gap we talked about was when you have kind of a high total protein but a low albumin. Some examples of monoclonal processes are plasma cell dyscrasias, and polyclonal is more HIV, Hep C, and autoimmune hepatitis. You know, and last thing we ultimately saw as the case presented, just kind of diffuse skeletal lesions, avid lymphadenopathy, and pleural masses. And we talked about that, you know, one thing to consider in that presentation are inflammatory processes like IgG4 related disease and other histiocytic diseases that can lead to kind of this infiltration in multiple organs. But ultimately, the diagnosis came from a biopsy showing adenocarcinoma with signet ring cells. And, Steph taught us that when considering where to biopsy, you want to try to balance where will be most diagnostically fruitful, but not high risk for the patient. So really a very, very complicated case. So thank you again, AMK, for presenting it.
Thank you everyone for being here. Again, Anne-Marie, Yasmin, Joy, thanks for joining us today, and we'll look forward to seeing you all next time.
Thank you.
Happy holidays for those we don't see before.
Bye.